M1, we have the distal metastasis. This is nothing issue. Now 1 minute, look here please. The Japanese classification I write here into you. It is divided, first of all, stomach into 3 sections. Section A, upper section, section vice versa, C, upper section, M, it is middle section, and A, it is the pyloric section. And according to lymphatic nodes, which is involved inside of, let's say it is not TNM system. It is the system which is included only portion of the stomach, which is involved in the problem, and the lymphatics, which is involved inside of it. Right, please, or remember, Japanese system work only with the cancer without distant metastasis. M grade will be 0. Let's say maximum what we have, it is a tumor with lymphatic spreading. That's if there are M, Japanese classification doesn't use atolls. Now look to me. Up to this Japanese classification, there are 16 main localization and 2, we can say, more localization. It is to show that it is not the mean, we call it 110, 111. But main localization is 16. From this 16 localization, right please, first six located in superior compartment. And they located superior compartment of peritoneal cavity, I guess, yeah, you understand? And they located along the greater curvature and along the lesser curvature of the stomach. Along the greater curvature of the stomach and along the lesser curvature. You can see here, guys, 1 minute, don't write here. First 2, it is the cardial. One is we call supracardial, second we call infracardial. Second one up in the level of the fundus. First one, it is low. Third one, we call the mid part of the lesser curvature. That's a middle portion of the. Fourth one, we call the fundus. We come to the greater curvature in the level of the fundus. Fifth one, we call suprapyloric. It is located just above the pylorus. Sixth one, we call infrapyloric. It is located. By the way, fourth one divided into 2. Upper one in the fundus, lower one in the lesser curvature in the level of gastric ligament. Another 16 located in retroperitoneal space. This is retroperitoneal space along the aorta, along the inferior caval vein, along the pancreas. Let's say this is also regional lymphatic nodes, but not in the peritoneal cavity, but in the retroperitoneal space. Last 2, it is 110, 111. They belong to thorax. This is diaphragmatical and upper portion, lower portion of the esophagus before passing through the esophageal aperture. That's why we put another numbering for them to show for you that they doesn't connect it with the main regional lymphatic nodes, 16 regional lymphatic nodes, which is included in this classification. That's it. By this Japanese grade, right, please, we describe 3 types of the classification. Classification number 1. 1 from 6 lymphatic nodes, or several from 6 lymphatic nodes, which is located by greater and lesser curvature. Grade 2, retroperitoneal lymphatic nodes. Doesn't matter, by the way, how many intraperitoneal is damaged. If it is passing into the retroperitoneal, it is second grade. Grade number 3, 110, 111. Let's say it is passed along the, we call it the inferior caval lymphatic tract, yeah, along the vena cava inferior, you know, we have great development. By the way, in the neck region, it is continuous to the internal jugular lymphatic tract, yeah, as you remember. Let's say we can see that the problems widespread to upwards, finally to reach the ductus thoracicus, and by the ductus thoracicus will be drained into the venous system, yeah. That's a lymphatic problem only spreading to upwards, yes. For the lower portions of the body, it is spread. For upper portions, it is goes to downwards. Yeah? They try to find in the left brachiocephalic vein because ductus thoracicus drain into the left brachiocephalic vein. That is the direction. That's I remember. Grade number 1, it is the ligaments of stomach, the first 6 group of lymphatic nodes which we described. Grade number 2, it is retroperitoneal group of the lymphatic nodes. Grade number 3, it is unfortunately last stage. Why? Because it showed that generally it is distant metastasis. you will understand that this is the distant metastasis and the thoracic group of the lymphatic nodes. Idea is understandable for you. Let's continue now, right, please, sign and symptoms. You know, I don't want to speak more about it because all signs and symptoms will be divided into two big groups. Right, please. Group number one, it is signs and symptoms which show the erosion of the mucous membrane of the stomach. I can say otherwise that it is signs and symptoms of the ulcer of the stomach. Or for example, I don't know, not the gastritis, but erosive gastritis, for example. Yeah, if we have erosion of the mucous. Anyhow, yeah, let's say gastritis, why not? So everything which, you know, pain, right, please, localization of the pain, it is the proper epigastrium region, mainly. Number two, it is dyspeptical signs, nausea, vomiting, heartburn, bile reflux into the stomach, possibly, yeah, we can see. Esophagitis, inflammation of the esophagus, and with heartburn in this region. Water brush, hypersalivation. You're absolutely right. Let's continue. Bleeding, intra-stomach bleeding, which we can see. We can see hematemesis. We can see melena, coffee ground bleeding. That's all type of the bleeding which is show formation of hemosiderin, because of the H chloride influence into hemoglobin. It is oxygenated. We see the black dark color, and it is show that the bleeding, or if it is profuse trauma of the big vessels, we can have the profuse hematemesis. Also, it is possible vomiting with fresh blood. Vomiting with fresh blood usually, guys, show that the bleeding is very profuse. Why? You know, the bile has, blood has base environment. That's why it can neutralize it, the acid of the stomach. That's why usually your patient will say you that then the bleeding is started, pain is disappeared. Because it is work like antacid. It is work like not antacid. It is neutralized the acid, aggressive acid inside of the stomach. Second type of the signs, right, please, it is abstractional signs. I say you that from 4 types, 3 types it gives the erosions, 1 type it gives the proliferation. Do you remember that we speak about Brodmann classification? They say if there are proliferation, we will have abstractions, guys. Right, please. Main sign it is the pyloric obstruction. Chronic constipation, fontanine vomitings after any food intake, asthenia, anorexia, anemias, pernicious anemias, B vitamin 12 anemias, because nothing doesn't normally work inside of the again, pain, distension of anterior abdominal wall, especially in upper portion. Very interesting sign which is described for it, portal hypertension. Portal hypertension, especially interesting, write it please, for diffuse form of the cancer. Why? Because I say it goes lymphogenically, and what is important, guys? In case of stage number 2, 1 minute look to me, then lymphatic nodes of retroperitoneal space involved inside of the problem, they can simply press the portal vein, which is located behind of the head of the pancreas. Let's say this is mechanical pressure of the portal vein, which gives, in approximately, if I don't mistake, 25% of cases, portal hypertension. Only diffuse form give it. Intestinal form, as I say, you give the metastasis by the hematogenous way. They said we don't see such kind of problems, generally, usually. Let's say, remember, please, this is all said. There's nothing, unfortunately, specific. As you understand, all these signs which I described for you before, it is same for any specific diseases of the stomach. Let's say, we can say that really clinical signs and symptoms only will help you to understand what the problem. And majority of these patients, long time, by the way, treated by the gastric ulcer. Before they make the fibrogastric duodenoscopy, before they take the biopsy and make the investigation. They treat it simply like the gastric ulcers, ulcer disease or gastritis. This is also, guys, you must understand me that the cancer which is resemble to specific disease of organ, unfortunately, in case of the prognosis, is not so good because we lose a lot of time for non-effective forms of the treatment. I don't think that if somebody will feel the small pain in epigastral region, at once will go to make the endoscopy or biopsy. No, we'll go to the pharmacy, we'll buy the pantoprazole, omeprazole, and we'll drink. Yeah, by the way, about the inhibitors of the proton pump. Again, I don't want to speak about it, but I find United States investigations into 25 persons, which is show that the long-term using of these inhibitors can also, not because of achloros, by the way, that is not connected with chronic achloros, decreasing of the level of the H-chlor, yeah? They doesn't explain, again, the mechanism of formation, but they show that dead persons have, especially first generation of the inhibitors, omeprazole. For example, in case of pantoprazole, yeah, not so high information. But
even they forbid it.
I don't know, friend. I cannot speak. I know. For me, I understand the mechanism, but I'm not responsible to teach you because till now it's not proved. But only one these investigation, then you will open the risk factors. I write about it. Yeah, it's not proved, but we have information that long-term using of the proton pump inhibitors can give such kind of effect. Let's continue. Write, please, the diagnostical investigations. Point number one. Point number one. All laboratory methods of investigations which is used for the stomach ulcer. Simple blood count, the ferments of inflammation, the acid phosphatase, the level, by the way, in majority of the cases, hematocrit is decreased, and bilirubin, because I say you, the absorptional processes inside of the stomach will be damaged. Especially, right, please, that is actual for diffuse forms. For diffuse forms. For diffuse forms. Unfortunately, guys, you know, yeah, CA1, we speak about circulated oncomarkers, but unfortunately, we can say that we don't have any specific biochemical test into fixation of circulated oncomarkers, which is show for us the diagnostically important for the gastric cancers. That's it. Right, or remember that we don't make tissue oncomarkers, please, how you want. All these genetical mutations which I described for you before, CDH1, for example, yeah, the most usual panels which we use, yeah, it is tissue oncomarkers, it is not circulating. That's a main type of investigation, instrumental, of course. Right, please, point number one. It is the contrast X-ray, plain X-ray by the contrasting. Method is not so much informative. It shows just defect in the mucous membrane, which can belong them to ulcer. Usually it is hypoplastic form, yeah, if there are defects, yeah. We call the niche sign. Remember the name, please, niche sign. That's like what you always say, crater sign, yeah. You see formation of the crater. That's like barium is go absolutely smooth into the mucous membrane, then the depression is formed. Or vice versa, you should see protrusion. Protrusion is much more usual for polyps. Yeah, if there are polyps inside of the stomach, you give the barium contrast and you see that there are some protrusions in the mucous membrane. The gold standard, of course, endoscopical investigation. That is, we can say, that is the situation that endoscopy, it is the main method of the diagnostical investigation. Why it's so? Comparable with another tumors which we studied before, for example, for the lung tumor, wall of the stomach is not so thick. That's why any tumor, doesn't matter, by the way, which stage is it, which T is it, anyhow is shown, except cancer in situ, of course. Cancer in situ doesn't give the volume. You don't see any problem in the mucous membrane. That's it. Usually we find it incidentally if you make, for example, some screenings. But for example, you make, person has the ulcer, something like this, you make the test into the Helicobacter biopsy. And incidentally, you find atypical cells inside of the mucous membrane. Majority of cancer in situ of stomach find it in such a way. Investigation of Helicobacter pylori, biopsy, if it is not the, of course, expressed test. Because if it is expressed, it is just you apply the chemicals and it is show colorings, yeah? If you make real biopsy, yeah, by the microscopy, histological, I mean, investigation, you can find these atypical cells. If not, no. Right, please, endoscopy with ultrasound. Endoscopy with ultrasound. A great method, you can see it here. Walls of the stomach shown by endoscopy with ultrasound by 5 rings. Remember, please, first 4 rings, it is the mucous membrane with submucous and with the muscularis mucosa. Let's say you can see 1, 2, 3, 4, 5. Let's say 4 first layers belong to the mucous membrane, submucous membrane, and together also with muscularis mucosa. Last layer, it is together muscularis propria and serous membrane. Let's say what the value of this method, 1 minute attention. You see not only intraluminal problems, but you see intra-wall, intra-tissue problems. Let's say you make in the same time 2 investigations, macroscopical investigation of the lumen and endoscopical investigation of the wall of the stomach. For example, you can see here hypoechogenic structure, which is passed up to the last ring, up to the serous membrane, yeah? As you understand, it is the T3 or T4, I don't know. Continuation, I don't know how it goes. Or for example, here the small problem, which is located in level of the first, second rings, yeah? It means it is inside of the mucous membrane, approximately T1 to 2. Let's say, remember, friends, this is also useful. Of course, CT MRI, of course, which show any problems of the soft tissue and stomach. But here you must understand that mainly CT and MRI for you will show the problem which is go outside of the stomach. Yeah. If the problem is localized in the mucous membrane, for example, yeah, or maximum, wall of the stomach is not so thick, guys. That's why you should understand that the volumetrical processes can be identified in 2 cases. Or it is both cases, then the tumor go outside. One case it is go outside to outside, second case outside to inside. It means outside from wall, or in the lumen, or in the peritoneal cavity. But anyhow, if it is localized inside of the wall, MRI can show the problem, but for what you need it? Why you needed 40 minutes to do it and to spend so much money if you can make endoscopical investigation with ultrasound? It's like just, it is unuseful. It is unnecessary. Right, please, scintigraphical investigation. Of course, we can use the scintigraphy because it is the tumor, it is concentrated, the radioisotopes, yeah? But again, scintigraphy will be best if you want to find the distant metastasis, not to find the primary tumor, yeah? For example, before the surgery, you need to understand, does it have the metastasis or not, because the treatment will be changed. Yeah, it will be great to make the scintigraphy to find all the spreading of the tumors, yeah? But not for primary tumor diagnosis. Only for the diagnostical investigation of the metastasis. Remember about it. Let's continue now. Right, please, the classical treatment included surgery except distant metastasis. And this classical surgery I want to say what is written in the text, but in the same time I don't want to say. It is written here, and in some books it is also can be proved that if the problem located inside of the mucous membrane, it is not recommended to remove the lymphatic nodes because in the future they can give the swelling, lymphadenitis, or something else. I don't agree with this. I have experience, and experiences show that you cannot recognize is it passed into the lymphatic nodes in case of not developed lymphadenitis. You must understand, guys, problem is happening not at once. We don't know 2-3 tumor cells is spreading to these lymphatic nodes, or no. Of course, if we will just make resection of stomach and remove, for example, damaged portion of without the removing of this lymphatic node, after a few times will be the great chance to have the recidives of the problem. That's in my opinion, anyhow, point number one, it's great to remove stomach together with the 6th group of the lymphatic nodes, which we described 2 minutes before. And second, it's very effective to make the adjuvant chemotherapy, even in the case of the first stages. Even in the case of the first stage. Again, I tell you, we don't know what is the passage of the tumor cells. Yeah, that's it. The best books today recommended not to do alone, except cancer in situ stage. Single stage, which doesn't need to provide chemotherapeutic treatment. By the way, for cancer in situ, I write here method of the treatment. You can see, look at please, endoscopical, mucosal or submucosal resection. If you want to know my opinion, this method I also don't accept. I don't accept it because of some reasons. We, again, cannot make so deep and histological investigations to understand problem is located only superficially to basal membrane, or maybe it is spreading deeper. In my opinion, in case of cancer in situ, don't make this monkey manipulation. This is really, it's not serious. Make the resection. Make the resection. Believe me, guys, our experiences show that after, for example, the distal resection or pyloric resection, person doesn't have any discomfort in the leg. Today, the persons, because of obesity, make the resection and live, I cannot say absolutely normal, but near to the normal. Let's say, don't be afraid so much from resection. Then you make so small, less invasive surgical manipulation, it gives the high chance for pathological process to be spreading. Let's say you don't want to leave the patient from you. You give the chance for him year by year to come for you, to pay the money, to make the continuation of the treatment. Guys, if you do surgery, do it in normal size. If you don't want to do surgery, don't do the surgery at all. But if you start the surgery, remove it to be sure that it will not become again. Let's say, right, please, according to the size of removed portion of the stomach, all surgeries we divided into 3 types, D1, D2, and D3. D1, it means the distal resection of the stomach. In the brackets, right, please, it is pyloric portion. Without removing of lymphatic nodes. As I say you before, for cancer in situ, that is the best decision, yeah? To make D1, to remove the portion of the stomach which is involved, but to not take the lymphatic nodes, because we know cancer in situ, it is not spreading form of the cancer. D2, you know, guys, again, there are the problems with our colleagues in foreign countries. They don't understand that complete removing of the stomach, it cannot be called portional removing of stomach cannot be called gastrectomy. Gastrectomy, it is complete removing of stomach. That's like, I suggest you, D1, to call resection of the stomach, not the gastrectomy, because you don't remove whole the stomach, you remove only portion of it. Really, D2 and D3, it is gastrectomies. Right, please, D2, then you remove whole stomach, together with whole 6 group of lymphatic nodes, which we described along the stomach. That is D2. D2, D3, it is removing of whole stomach, together with neighboring lymphatic nodes, and together with splenic, pancreatic, sometimes and celiac group of the lymphatic nodes, which is located in retroperitoneal space. Idea is understandable for you. That's it. Firstly, we can remove only piece of the stomach if it is non-spreading problem. If there are involving of some lymphatic nodes, yeah, for example, stage 2, yeah, or stage 3, we remove the stomach with the lymphatic nodes which is located along the stomach. And if it is T3 and more, lymphatogenous spreading of. By the way, guys, I think you understand that in case of intestinal type of the tumor, which is spreading hematogenously, that is not so active. Because we don't, for that type of the tumor, or you will make only D1, portional resection, if it is not spreading, or you will not make surgery at all, if there are distant metastases in different places. Idea is understandable for you. Let's continue now, please. Right, please, technique of the surgery. In case of the distal resection, we make classical surgical manipulation. Access, usually, it is superior median laparotomy or superior horizontal left. Superior horizontal left, why? Because majority of the stomach, it is passing the left side, yeah? Superior horizontal left. On the level of the stomach, we start separation from the level of the greater curvature, from up to down. From up to down. Right, and remember, please. Right, and remember, please. Right gastroepiploic artery ligated completely. Left gastroepiploic artery, we don't ligate it, because it is supply non-removable portion of the. And guys, look here, please. Here, situation another. Sometimes you think that it is absolutely safe to resection of the stomach in case of the ulcer disease. No. In case of ulcer disease, why you make subtotal resection? To remove all the cells which is productive H4. Here we don't have that problem. I don't need to remove 2/3 of the stomach because that is not the ulcer. That is just the tumor. I need to remember locus of its location. Right, then we come to the level of the lesser curvature. This connection we start from down to upwards. Why? Because we must to completely ligate it, the right gastric artery from its root. In case of left gastric artery, usually only the most right terminal branches in the level of anastomosis. Majority of the left gastric artery is not removed. Classically after, guys, 2 intestinal clamps in the proximal portion. First one is occlusional, second one is crushing. 2 in the pyloric region. Again, first one is crushing, second one is occlusional. And resection between them. Best anastomosis which we perform here, it is the anastomosis of the root. Why anastomosis of root is better than others, guys? To prevent formation of the bile reflux. Bile reflux, and to prevent formation of the proximal loop syndrome. Next year, if we will work together, I will read you the lecture about diseases of operated stomach. Dumping syndrome, the sign of the proximal loop. This is the main problems after the surgery in the stomach. So, root anastomosis prevented formation of such kind of the problem. Why? You absolutely disconnected the bile system from the stomach. Let's say all refluxes of the bile inside of the stomach stand impossible. How we do it? You inserted your finger below the transverse colon and you push it from right side to left side. Then you come little bit left from the midpoint, you palpated the ligamentum duodenojejunales. Otherwise we call it trace. Yeah? It means you find the first loop of the jejunum. Approximately 50 centimeter below it, remember please, 50 centimeter below it, you take the first loop of the jejunum. You make the disconnection, resection of this first loop, you insert it into upwards, and you can apply two types of anastomosis. Here you can see side to side. Much more usually we apply anastomosis side to end, between the jejunum and between the small intestine. Side to end anastomosis, little bit dangerous because natural size of your jejunum nearly 3.5 centimeters. Let's say then you apply 2 layers of the suture, you can decrease it critically. In majority of the cases, it is not problem. Why? Because first 2 weeks, usually you make the or enteral low feeding or parenteral feedings. That's it. First time for the regeneration, you will have enough time, yeah, to have normal regeneration and to prevent stenotization. That's a side-to-side anastomosis from that point of the view is much more preferable. Then proximal loop, which I say you 50 centimeter long, you make by Brown anastomosis. End to side with the distal loop. That's how you form the classical roux anastomosis. Remember about it. Let's continue now. Right, please. The radiator, about endoscopical resectional surgery. 2 types of endoscopical resectional surgeries we do. Right, please. First one, it is the resection of the mucous membrane. Second one, it is mucoso-submucosal resection. Then you make the resection up to the muscularis. Mucosal, submucosal resection. Consequence of the stages. 1 minute, look to me. First of all, usually we make the colorings of the tumor region. We have the special dyes. Intravenously, we injected it into vascular system, and it gives the hypercolorization of the region of cancer in situ. Yeah? Mainly it is for the cancer. Because it has the better supplement, you can see that the region of the cancer in situ, it is greatly vascularized. So you understand the locus. After this, guys, using the electrocoagulation around of this region, you started to separate, or mucous membrane. By the way, submucous resection is much more simple. Because as you know, under the submucous layer, we have loose connective tissue between submucous and muscular, and we can simply disconnect it. Mucus is firmly fused with submucous. Let's say removing only mucous membrane usually gives the bleedings. Then you make submucal resection. You remove in the level of loose connective tissue. Let's say not so many vessels is damaged. Yeah? Surround of this place here, as you can see, we make coagulation, we coagulated vessels. If it is necessary, you can apply the metallical stamps in the vessels, yeah, to close it completely. Finally, we roundly resect it. We apply the stamps, surround it is submucous form of the resection. Yeah, you can see mucous membrane together with submucous layer, and we make the coagulation inside of it. After approximately 1 week, the firm, strong scar is formed inside of this resectional zone, and in the future the person is normally lived without any problem. Right, please, the prognosis. How long time I have?
10 minutes.
Prognosis. In case of the local form of the tumors, 5-year survival, it is more than 50-55%. In case of diffuse spreading form of the tumors, it is less than 10%. About chemotherapy, guys, there are 2 classical lines of the chemotherapeutic treatment, 4 medicines and 3 medicines. You will read it, you will look it. Radiotherapy is not so much useful for the gastric cancer. We have some information I included in the slides that say you will read. That is today. Now look, next hour